Thank you very much for the introduction, and I sincerely apologize for not being with you. I would like to cordially thank Professor Kotsis for the kind invitation to take part in the 2023 International Meeting on Cardiometabolic Diseases, Obesity, and Diabetes. And the subject of my lecture will be the prognostic value of arterial stiffness in type 2 diabetes mellitus and the effect of newer anti-diabetic drug classes on it. Herein I present my conflict of interest, and we know that type 2 diabetes mellitus is a growing pandemic. And according to so I was talking about type 2 diabetes mellitus and the growing pandemic. And we know that according to the 2021 IDF Atlas data, that more than 500 million people around the world suffer from diabetes mellitus, and 90% of them from type 2 diabetes. And the projections are rather pessimistic, since we will have within the next 2 decades more than almost 50% increase in the number of patients affected by diabetes mellitus. And on the other hand, we know that atherosclerotic cardiovascular disease is the #1 killer worldwide, as more than 18 million patients worldwide die due to cardiovascular disease. And cardiovascular disease accounts for almost 1/3 of all global deaths. Of course, we know that there is a close interconnection between diabetes mellitus and atherosclerotic cardiovascular disease. And what about the economic burden besides the burden, the emotional burden, and the burden for the patients? According to data from the European Society of Cardiology, the total cost for the care of patients with atherosclerotic cardiovascular disease in its different forms, only in the European Union, is about 300 billion euros each year. So we understand that the cost is extremely high. What about the connection, the relationship between type 2 diabetes mellitus and cardiovascular disease? We know that there is a close interconnection between these two entities, and that subjects with type 2 diabetes have an increased risk for cardiovascular disease, namely coronary artery disease, cerebrovascular disease, and of course peripheral arterial disease. And it is also well established that even in the absence of other certain risk factors like smoking, obesity or hypertension or chronic kidney disease, even those patients, even those being younger, also have an increased risk for cardiovascular disease compared to the general population. And we also know that, as being evident, patients with type 2 diabetes mellitus also die more due to cardiovascular disease, since cardiovascular disease accounts for more than 2/3 of all deaths observed in this population, while most patients die due to sudden cardiac arrest, due to silent coronary artery disease. And according to data from the Swedish registry, we know that despite the significant progress in the early diagnosis, the monitoring, and the appropriate pharmacologic treatment of patients with type 2 diabetes, still patients with type 2 diabetes die with higher rates compared to the general population due to cardiovascular disease, while the burden of cardiovascular morbidity is higher compared to the general population as well. What about arterial stiffness and target organ damage? We have heard many of those I was planning to present in the previous lecture by Dr. Anza, and we know that arterial stiffness has significant prognostic role in atherosclerotic cardiovascular disease, and we also know that carotid femoral pulse wave velocity assessed with different methods, tonometric, oscillometric, is a gold standard for the assessment of arterial stiffness in clinical practice. Well, we also know that aortic pulse wave velocity assessed by magnetic resonance imaging is also a significant marker of arterial stiffness and has been used over the last 2 decades in several studies, observational mainly, for the assessment of arterial stiffness in different patients' population, like those suffering from hypertension or from end-stage kidney disease. I will not talk more about carotid femoral pulse wave velocity since we have heard significant evidence in the previous lecture. Just one comment about the comparison between oscillometric and tonometric methods to assess pulse wave velocity. According to a recent study, there is a moderate agreement between 24-hour pulse wave velocity and carotid femoral pulse wave velocity assessed in the office. And we know that pulse wave velocity levels vary according to age and blood pressure, besides the presence of other factors that exacerbate arterial stiffness. And therefore, in 2010, we had, for the first time, the definition of pulse wave velocity thresholds according to age and blood pressure levels of the enrolled participants in a large sample of population. And according to the most recent 2023 SH guidelines, we have a threshold of 10 meters per second for carotid femoral pulse wave velocity. That is a threshold of increased cardiovascular risk for patients aged over 50 years old. We heard about the level of evidence regarding the importance of pulse wave velocity for target organ damage assessment in patients with hypertension, level of evidence beta. And what we need to know also is that despite the fact that pulse wave velocity is sensitive to changes, we have limited evidence regarding the prognostic value of changes in pulse wave velocity levels, and this is a significant problem in its use in routine clinical practice. What about arterial stiffening and its consequences? First of all, arterial stiffening increases systolic blood pressure, decreases diastolic blood pressure, and therefore we have systolic hypertension, and therefore we have an increased risk for left ventricular hypertrophy and myocardial dysfunction, and thus the patients with enhanced arterial stiffness experiences a significantly increased risk for development of heart failure, and on the other hand, we have decreasing diastolic blood pressure and therefore an increased risk for coronary hypoperfusion, while arterial stiffening increases also the risk of renal impairment and development of chronic kidney disease as it increases intraglomerular pressure and increases the risk of progressive renal impairment. We also heard about early vascular aging, and arterial stiffness is a significant determinant of early vascular aging, and we also know that diabetes mellitus is a significant factor contributing to early vascular aging, while even patients with prediabetes with impaired fasting glucose or impaired glucose tolerance have an increased risk for progressive arterial stiffening. We have two hallmark meta-analyses regarding the prognostic value of pulse wave velocity in cardiovascular disease. The first one by Vlachopoulos and colleagues, published in JACC in 2010, and the second updated meta-analysis by Ben Slom and colleagues, also published in JACC in 2014. And we know that pulse wave velocity is associated independently with an increased risk of cardiovascular morbidity and cardiovascular mortality and all-cause mortality. What about arterial stiffness in type 2 diabetes mellitus? In the meta-analysis by Ben Slom and colleagues, it was shown that patients with concomitant diabetes mellitus for the same levels of pulse wave velocity had increased risk for cardiovascular disease compared to subjects without diabetes mellitus at baseline, while we have dedicated data for the population of diabetes mellitus patients. For example, the hallmark Rio de Janeiro study, published by Cardoso and colleagues in Diabetes Care 10 years earlier, which showed that an increase in aortic pulse wave velocity by 1 meter per second is associated with a significant increase in the risk for major adverse cardiovascular event by 13%, while the threshold of aortic pulse wave velocity greater than 10 meters per second is associated with a significant and extremely increased risk for major adverse cardiovascular event, although the effect for all-cause mortality was not sustained significant. And according to another relevant observational study by Wickman and colleagues in the setting of primary care, it was also shown a similar finding that an increase in aortic pulse wave velocity levels by 1 meters per second is associated with an increased risk by 14% in the risk for atherosclerotic, for a major adverse cardiovascular event, as shown in the multivariate Cox regression analysis. According to a more recent sub-analysis of the Rio de Janeiro study, Cardoso and colleagues showed in a publication in 2022 that not only increase, but also decrease in pulse wave velocity matters and has prognostic value concerning cardiovascular morbidity and mortality in patients with type 2 diabetes mellitus. What about the association between arterial stiffness and microvascular complications of type 2 diabetes mellitus? Also, data from the Rio de Janeiro study are indicative of a significant association between arterial stiffness and diabetic retinopathy and diabetic peripheral neuropathy. However, we have data also from the Greek population. Antonopoulos and colleagues 2 years earlier showed that despite the fact that we have an increased relative frequency of microvascular disease as type 2 diabetes duration progresses, and that we have also increased pulse wave velocity levels as type 2 diabetes duration and, of course, aging progresses. However, pulse wave velocity is not associated either with the presence of microvascular disease or with the progression of microvascular disease in patients with type 2 diabetes mellitus, and therefore it might not have predictive value regarding the microvascular complications of type 2 diabetes mellitus. And before proceeding to the next section, we should always assess, especially at baseline, our patients with type 2 diabetes mellitus regarding their cardiovascular risk. What about the newer anti-diabetic drug classes and their effect on arterial stiffness indices in type 2 diabetes mellitus? We are happy to have two great anti-diabetic drug classes, namely SGLT2 inhibitors and GLP-1 receptor agonists, in our treatment armamentarium against type 2 diabetes mellitus pandemic. And we have hallmark cardiovascular and renal outcome trials during the last decade showing and documenting the significant cardiorenal benefits of those two drug classes. Therefore, according to recent EASD and TADA consensus statement, and according to the recent ESC guidelines for the treatment of patients with diabetes mellitus, these two anti-diabetic drug classes are prioritized for use in patients with type 2 diabetes mellitus and concomitant atherosclerotic cardiovascular disease or heart failure or chronic kidney disease or different combinations of these nosological entities. What about SGLT2 inhibitors and arterial stiffness? The first relevant randomized control trial was that conducted by Stripe and colleagues and published in Circulation 6 years earlier. Stripe and colleagues enrolled 76 patients and randomized them in a crossover design to empagliflozin or placebo for 6 weeks for its treatment, and showed that empagliflozin versus placebo resulted in a significant improvement, a significant decrease in pulse wave velocity levels, both at the level of office and in 24-hour pulse wave velocity levels, although the numeric change was quite low. According to another randomized control trial in the field, Ramirez and colleagues in a publication in Journal of Hypertension in 2019 showed that addition of canagliflozin to amlodipine compared to addition of perindopril to amlodipine in patients with type 2 diabetes mellitus and essential hypertension resulted in a significant decrease in pulse wave velocity after 6 months of treatment. However, I think that the numeric change was quite high since canagliflozin treatment resulted in a decrease in pulse wave velocity levels greater than 3 meters per second. And I think that we should have some doubts about the design of the study uh, due to the very high decrease in pulse wave velocity levels in both treatment groups. In a Greek randomized controlled trial published in JAHA 3 years earlier, Economidis and colleagues enrolled and randomized 120 patients with type 2 diabetes mellitus to insulins, liraglutide, empagliflozin, or combination of empagliflozin and liraglutide, and showed that 12 months of treatment with empagliflozin resulted in a significant decrease in pulse wave velocity levels, while according to another Greek randomized controlled trial by Papadopoulou and colleagues, dapagliflozin treatment compared to placebo in patients with type 2 diabetes mellitus resulted in a significant decrease in 24-hour pulse wave velocity levels assessed via mobilograph device after 3 months of treatment. Of course, we also have negative trials. For example, in the trial conducted by Karayende and colleagues, it was shown that addition of dapagliflozin to ramipril treatment compared to ramipril alone in patients with type 2 diabetes mellitus did not have any significant effect on pulse wave velocity levels. And it is important to note that a slight increase in pulse wave velocity levels was observed in both treatment groups after 6 months of treatment. And according to another Greek trial by Bechioulis and colleagues from the University of Ioannina, it was shown that 9-month treatment with empagliflozin did not have any effect on pulse wave velocity levels after 9 months of treatment. And what about the evidence retrieved from meta-analysis? 1 year earlier, we conducted a meta-analysis of randomized controlled trials and showed that SGLT2 inhibitor treatment does not have any significant effect on pulse wave velocity levels in patients with type 2 diabetes mellitus. Of course, in this forest plot, we also have trials conducted in heart failure population without diabetes mellitus at baseline. However, subgroup analysis, according to the presence or absence of type 2 diabetes mellitus, did not document a significant effect of SGLT2 inhibitors on pulse wave velocity levels, a finding that was later confirmed by another network meta-analysis by Wang and colleagues, who showed that SGLT2 inhibitor treatment does not affect, according to currently available evidence, pulse wave velocity levels compared to placebo or active comparator. And what about GLP-1 arrays and arterial stiffness? The first chronologically trial to be published was that conducted by Scalzo and colleagues, who showed in 2017 that exenatide treatment in patients with type 2 diabetes mellitus resulted in a significant decrease in pulse wave velocity levels after 3 months of treatment. And according to another Greek randomized controlled trial by Lavadiari and colleagues, treatment with liraglutide compared to metformin in patients with type 2 diabetes mellitus resulted after 6 months of treatment in a significant decrease in pulse wave velocity levels, whereas metformin did not affect levels of pulse wave velocity. Of course, we have also negative trials, such as that conducted by Peinman and colleagues, who utilized aortic pulse wave velocity assessed via magnetic resonance imaging and showed that 6-month treatment with liraglutide compared to placebo did not have any significant impact on pulse wave velocity levels. More recent data suggest that dulaglutide, another GLP-1 array with established cardioprotective effects, results in a significant decrease in pulse wave velocity levels in patients with type 2 diabetes mellitus, and this decrease was shown only after 3 months of treatment, whereas this effect was sustained after 9 months of treatment when dulaglutide was compared to conventional therapy. And just to remind the results of the study by Economidis et al., who showed that besides empagliflozin, also liraglutide had a significant effect on pulse wave velocity levels, whereas they also showed that the combination of empagliflozin and liraglutide had the greatest effect on pulse wave velocity levels after a year of treatment, whereas we have also the recently published randomized control trial by Patoulias and colleagues who failed to show a significant effect of liraglutide on pulse wave velocity levels in patients with type 2 diabetes mellitus. And according to the previously mentioned meta-analysis by Wang and colleagues, it seems indeed that GLP-1 RA treatment has a significant effect on arterial stiffness as it decreases pulse wave velocity levels more than 1 meter per second, according to the evidence we have to date. Of course, we have some randomized controlled trials currently recruiting patients and planning to assess the effect of SGLT2 inhibitors and GLP-1 RAs on arterial stiffness indices in patients with type 2 diabetes mellitus, and we have to expect for these results. However, none of these trials is a trial with a large sample size, and none of those trials is a head-to-head trial comparing different SGLT2 inhibitors or SGLT2 inhibitor with GLP-1 RA, unfortunately. Of course, we referred to newer anti-diabetic drug classes. We have also novel anti-diabetic drug classes like tirzepatide, an agent that is already FDA approved for the treatment of type 2 diabetes mellitus and is already incorporated into the ADA-ASD consensus statement and guidelines for the treatment of patients with type 2 diabetes mellitus. However, we do not have any evidence regarding the effect of tirzepatide on arterial stiffness, whereas we have also in phase 2 trials different agents like oral small molecule GLP-1 RAs or cagrilintide for the treatment of patients with type 2 diabetes mellitus, agents that have shown significant and very promising effects on glycemic control, body weight reduction, and significant improvement in cardiometabolic risk factors. However, of course, we do not have any data regarding their effect on arterial stiffness indices, while we do not have, of course, any data regarding their cardiovascular safety or probably efficacy. And to sum up, arterial stiffness can also predict cardiovascular morbidity and mortality in type 2 diabetes mellitus. Current evidence regarding the effect of newer antidiabetics with proven cardiorenal benefits on arterial stiffness is rather limited, as GLT2 inhibitors do not seem to exert a significant effect on pulse wave velocity levels in patients with type 2 diabetes mellitus, while GLP-1 RAs might improve arterial stiffness in type 2 diabetes mellitus. Overall evidence remains inconclusive, and we do not know if the effects on arterial stiffness mediate their cardiovascular benefits, while currently no evidence regarding the effect of novel antidiabetic drug classes on arterial stiffness exist. Thank you so much for your attention.